normal pelvis, now the child can pass, or favorable pelvis. Is it clear? In the case of favorable pelvis, the child can pass through the birth canal. So all this is clear. So this measurement here is called clinical pelvimetry. Is it clear? Now, apart from clinical pelvimetry, you can have also radiologic pelvimetry, which is done with a CT scan. By the CT scan measure are going to measure now all these different values, and then are going to tell you. Now, see, clinically, you can measure another element which can be helpful, which is called the transverse diameter. So, measure the transverse diameter. You instead put your finger, and when putting your finger, try to feel for the two ischial spine. Is it clear? So, this is actually quite difficult to feel the two ischial spine. You feel one ischial spine, you feel the second ischial spine, and then you approximate the distance between the two ischial spine by placing your finger as such. Is it clear? You feel one ischial, you feel the other ischial, you approximate the ischial spine by placing your finger as such. Is it clear? When you place your finger, you can approximate the distance, and that distance between the two ischial spine corresponds to the transverse diameter. Is it clear? Corresponds to the transverse diameter. Is it clear? And usually the transverse diameter has also to be greater than 11 centimeters, because you need to know that what the biparietal diameter of the child. Let's say that you have the head of the child as such. Is it clear? The head of the child, then the neck of the child, then the earth shoulder. So let's say that the child is like this. Is it clear? So this biparietal diameter like this of a child, is it clear, is usually constant and is supposed to pass through the obstetric conjugate at the level of the pelvic brim, and then later on is supposed to pass through the transverse diameter of the pelvic inlet, because the marker of the pelvic inlet is a transverse diameter. Is it clear? It also needs to be greater than 11 centimeters. Why? Because this biparietal diameter ranges from 9 to 10 centimeters. Is it clear? If the biparietal diameter is normally this, and then the pelvis do not correspond to this diameter so that it can pass, you are going to have different borderline pelvis. Is it clear? Now, provided that the child has a biparietal diameter which is greater than 10 centimeters, when you have a child having a biparietal diameter greater than 10 centimeters and a mother having a favorable pelvis, in that case we call that instead cephalopelvic disproportion. Is it clear? So I hope you're understanding the different elements which are involved here. Is it clear? The first one was the different pelvic types. Is it clear? When you have a problem, it is this different pelvimetry can either be divided with a maternal problem or a fetal problem. Is it clear? Now you need to know that what borderline pelvis or contracted pelvis is a problem of the mother. Contracted pelvis is a problem of the mother, meaning that what the pelvis of the mother is not favorable such that the fetal head can pass. Is it clear? But now when you have cephalopelvic disproportion, it's instead the problem of a child. Why? The head of the child is bigger than the normal birth canal diameters. Is it clear? So let me just come again. If you come here and then you measure that the obstetric conjugate is less than 8 centimeters or 9 to 11 centimeters, and then the child has a normal biparietal diameter, so the obstetric conjugate is less than 8 centimeters or 9 to 11 centimeters, and the child has a normal biparietal diameter which is 9 to 10 centimeters, it means that the child is normal but the mother has a problem. So it's a problem of contracted pelvis or borderline pelvis. But now if the child instead have a biparietal diameter which is greater than 10 centimeters, and then the mother has a normal or favorable pelvis, but the child cannot pass because the child head is greater than 10 centimeters, that one is called cephalopelvic disproportion. Is it clear? And there are risk factors for cephalopelvic disproportion. The first one is macrosomia. When all the risk factors of fetal macrosomia, this macrosomia and all the risk factors of fetal macrosomia. And the second risk factor, the risk factor of fetal macrosomia, we can have gestational diabetes, we can have diet of the mother. Is it clear? We can have the genes of the parents. Is it clear? It's mostly the genes of the father. We can have the male sex. Is it clear? Generally they have a bigger body than a female. Then we can have diseases like in the case of hydrocephalus. Is it clear? If you have hydrocephalus, generally these children are going to have a very huge head, and other diseases like hydrop fetalis. Is it clear? Hydrop fetalis. So those are the different risk factors for cephalopelvic disproportion that you are going to have. Why the risk factor of borderline pelvis is not actually a risk factor, they are born like that, so it's mostly as a result of the genes. Is it clear? So if a woman has a small size pelvis, based on her genes, she should also marry a man that is also having a small size pelvis, so that the genotype should not have a very huge body. Is it clear? So when a woman has a small size pelvis, let her marry a man that has a genotype with children of small size, else she's going to have a child that is going to be very huge, and they're going to produce a cephalopelvic disproportion. Is it clear? So those are the different types. So even a woman that has a borderline pelvis, she can give birth provided that the biparietal diameter of the child is normal. Is it clear? Or is lower than the normal. Is it clear? So she has to marry somebody that has a genotype with small small genes. Is it clear? So those are the different elements that you must bring out from the history. Now the next one now is the history of the passenger that we're going to see in the next video.